Thank you very much for participating in Luncheon Seminar 2 of APASU Oncology 2023 Seminar, co-sponsored by Chugai Pharmaceutical Company Limited today. If you joined the meeting online, you can also use the Q&A chat box to post your questions. To begin, we have few words from Dr. Tatsuya Yamashita, Associate Professor, Advanced Preventive Medical Sciences Research Center, Kanazawa University, who is the chair today. Dr. Yamashita, please.
Okay. We will start Luncheon Seminar 2. Today's speaker is Professor Sadahisa Ogasawara. I will introduce briefly. His current position is Associate Professor, Department of Gastroenterology, Chiba University, and his area of interest is only hepatocellular carcinoma. And he graduated Chiba University, and he is now 2022. He is from 2022. He is Associate Professor of Department of Gastroenterology, and he get 3 awards from JDDW or Gilead Research Scholar Program. Okay, today's title is Unlocking the Potential of Combination Immunotherapy in Advanced Hepatocellular Carcinoma. Please, Professor Ogasawara.
Thank you for kind introduction, Professor Yamashita. My name is Sadahisa Ogasawara from Chiba University, Japan. Before starting my presentation, I would like to great gratitude to Professor Ueno as his colleague and also APASU organized committee of this Congress for giving me a great opportunity to talk here today. Today I would like to talk about unlocking the potential of combination immunotherapy in advanced HCC. So here you can see my COIs. And also, this is an introduction slide. As you all know that about HCC, but however, the HCC due to the complexity of disease and delay of development of systemic therapy, it has lagged behind other malignancies in both clinical and research aspects. This is one of the problems. And also, as you know, that HCC patients are treated by hepatologist, surgeon, as well as oncologists. It depends on the region and facilities. So these kind of the people's collaboration is so important for developing research and also clinical aspects. So I think these kind of meetings are so important for the HCC's treatment development. So today's topic is I would like to share about the current status of disease and treatment of the HCC from the perspective of physician in clinical practice. I work in from the Chiba University. This is located in the Far East area of Japan. It's near Tokyo. And also number of new patients per year is more than 150. And also the number of the patients treated per year is more than 700. So I would like to share the data from the institution. So today I have 60 minutes. So I would like to start from this kind of slide. As you know that previously, HCC is the viral hepatitis disease, but currently, in Japan, national NAFD or non-B-non-C-related HCC are so increased. However, look at the overall, still HBV virus-related HCC are more majority, and also the 966,000 people were diagnosed with liver cancer. It's including not only HCC, but also the cholangiocarcinoma. But the 5 years survival rate is only 18% in overall. And also 830 patients are deaths in this disease. So it is one of the unmet medical needs of the healthcare of the mainly Asian Pacific region. Also, natural history of HCC, as you know, the risk factor is this kind of disease, but we all know about some of the patients, moving to cirrhosis and the occurrence rate of HCC are so increased. However, that liver is so complex disease, so liver immunology across the spectrum from healthy to inflammation and oncogenic. So continued inflammation and fibrosis change the immune environment of the liver. So this is one of another point. So we are so difficult to treat in immunotherapy on HCC. Also, main genetic alternation have been also clarified, and also one of the major gene mutation third, but this is undruggable mutation, so we cannot use this kind of mutation for the drug development. This is a big difference between the other malignancy, such as lung cancer. And also, we have already known about molecular immune classification of HCC, and these two papers are so important, so please check about after if you go to home. But we just summarize about purification class and non-purification class. So these kind of separate between the main HOZ or self differentiation on genetic features on the immune features, also vascular information and serum AFP levels. So these kind of completely correlate with this kind of profile of the node, origin of the nodule of the HCC. Also, this is another problem. Does HCC only arise from cirrhosis? The answer is no. So there are some of the additional factors of the occurrence of HCC without cirrhosis. This is one of the difficult points. One of the main causes is the integration of viral, mainly HPV and also AAV2. This is one of the patients who are undetectable or the out of surveillance patients. So that's why we sometimes face on the patient without cirrhosis. And also the cirrhosis and the occurrence rate of the NASH-related HCC is 0.3% to 0.6%. Also also NAFLD patient without cirrhosis, we have not known about data, maybe 0.04% or 0.3% per year patient occurred HCC per year. But you can see that really these rate are low, but so many patients we have the face on a non-cirrhotic NAFLD related non-cirrhotic NAFLD or NASH patient in a real world practice, because we have so huge population of health lifestyle disease. But so when we look at the non-cirrhotic patient from the HCC side, 40 to 50% of fatty-related HCC arise from non-cirrhosis. So this is another problem for the difficult to detect surveillance from the non-viral related HCC patient. This is really similar style, but in Japan, 22.3% of prevalence of NAFLD, nearly 20 to 50% in the Asian Pacific region. So now we can eat a lot of great food in daily life. So that's why the HCC patients are still increasing from this kind of population. And also, things are changing because we have a national hepatitis B immunizing program this is the data from Taiwan, but if you prevent HCV, occurrence of HCC rate is decreasing, and also the nucleotide analogous decreasing rate of the HCC occurrence. So that's why the rate of the viral hepatitis B related HCC is decreasing now. And also, Japan was the country with a high incidence of HCV previously, but now we can completely eradicate HCV virus. So that's why we can see, we cannot see the patient who have a HCV positive patient without SVR in daily practice. So this is the advanced HCC patient after HCV eradication. We sometimes saw this kind of patient. She is 50s male, eradicated HCV 12 years ago without proper follow-up. Unfortunately, she could not receive a proper follow-up during this period. And the diagnosis after visiting medical clinic for the nausea and fullness of the abdomen. Unfortunately, there are so many ascites with the main portal vein invasion. And risk of development HCC exists even as a HCV eradication. This is another problem we have to take care about. So I'll just summarize about my first part of my talk. Two factors are changing disease landscape of HCC. First is the revolutionary progress in antiviral treatment for both HBV and HCV. And also second part is the market increase in lifestyle-related disease. So we have to know this kind of two information for treating about not only HCC, but also the whole type of the liver disease. So you can see that the rate of non-viral HCC patient receiving systemic therapy. This is the first report. that's why I wrote around 2010. At that period, only 26% of patients are non-viral population. The majority of HCV and some of the HBVs, including this kind of report. But around 2020, nearly 50% of the HCC will occur from the non-viral population in who receive systemic therapy in Japanese general practice. Also, next part, I would like to summarize about the history of AC treatment in Japan in the last 30 years. This is the report from the Professor Okuda from Chiba University. Around 1980s, which when I was born, the overall survival of HCC was less than 12 months. However, that nowadays, the overall survival of HCC patients in Japan are more than 80 months. It's dramatically changing these 30 years. What happened in Japanese field practice? First of all, establishing surveillance system, that's kind of early detection and early intervention. These kind of two factors strongly affect to prolong the overall survival of Japanese population. Also, treatment with high-quality techniques, including complete cure control intrahepatic region. So these kind of factors really change about overall survival in Japanese field practice. Also, enclosing high-risk patient and insurance surveillance is so important. That's why the high-risk population gathering to the high-volume center of Japanese, local area or the central part of Japan, and those, institutions tried to do a high intensity of surveillance program, and that's why we can detect the HCC as early as possible. And we use ultrasound and also tumor marker as well as dynamic CT or EOB MRI currently. Also, surveillance away from the high-risk patient encourage of the high-risk patients in special medical affairs. So development diagnosis so improvement. So we have a lot of knowledge from this kind of, early detection, such as that's why we can diagnose HCC without imaging. Without the pathological diagnosis, we can diagnose HCC by imaging. This is a very unique point compared with other malignancy. And also increased number of early diagnosis, moving on to establish technique for radical and local treatment. So that's why the Japanese doctor or physician or surgeon has that so highly technique of the local therapy or the surgical reduction. So these kind of things are whole of these kind of things are affect to the prolong the prognosis in Japanese population. So you can see the review article from the gastroenterology 2016 written by the Dr. Bruce in BCLC. He said in this article, early detection and appropriate radical local treatment improve prognosis. So this kind of surveillance system, early detection and early intervention and prolonged survival is one of the standard treatment strategy, not only Japan, but also the whole over the world in the currently. So next part, I would like to talk about systemic therapy. So what happened in HCC over the past decade? It means about 2010 to 2020. Around 2010, we have only sorafenib. Of course, sorafenib was one and only agent for advanced HCC, and this kind of VEGF TKI had a modest impact for the HCC patient, but not so strong impact. Nowadays, we can use about immunotherapy. This is the main topic of my talk today. Now, you can see that first around 2010, we tried to develop a VEGF TKI such as not only sorafenib, but we tried lenvatinib, we tried beribanib, which is not available drug, unfortunately for the negative phase 3 trial, and we also regorafenib and also cabozantinib. This kind of VEGF TKI prolong patient survival. But nowadays, the main tool of our treatment is immunotherapy, such as atezolizumab or durvalumab or durvalumab monotherapy. In some of the countries can use about nivolumab or ipilimumab as well. So this is trial design of, as you know, you may not have already known about that this trial, UMBRELLA 150 trial. This is game changer of the HCC treatment. Atezolizumab versus sorafenib. This is the first trial, which improved the overall survival, superiority compared with sorafenib. So you can see the result, a great result, and p-value is less than 0.01, and overall survival of atezolizumab not reached, and sorafenib 13.2 months, and they are tolerable adverse events. That's why we use this kind of combination therapy in daily practice currently. And nowadays we have another positive study from the other company called Himalaya. This is combination therapy of durvalumab and tremelimumab, which is anti-CTLA-4 agent. And these two combination therapy are currently recommended as a standard treatment of advanced HCC. So let's summarize about what kind of agent we can use in daily practice in Japan. We can use regimen. It's amazing for when I was start from this treatment in 2010 or 2009. But we can use two kind of combination immunotherapy, and also we can use about single use of immunotherapy, such as PD-L1 agent called durvalumab in monotherapy, and also we can use about 4 kind of VEGF TKI, one anti-VEGF-R2 antibodies drug. So 8 regimen are available in Japanese field practice. You can see that the Japanese treatment algorithm of the HCC, it's really simple. We just, of course, the indication systemic therapy and no indication of surgical resection, liver transplantation, local ablation stays. If the patient had an indication, those kind of treatment, of course, you have to select this kind of treatment. But and also HPA patient with a good performance status, this is a 2 factor which I have to notice about this point. But if the patient indicated to the combination immunotherapy, we can use even atezolizumab or steroid regimen, but there are no data for which should be used. And after that, after failure of this kind of treatment, we use about other agent, VEGF TKI or other combination therapy. This is Japanese algorithm. Of course, if the indicator of combination therapy is no, you have to start with sorafenib or lenvatinib in initial treatment. This is Japanese algorithm. So next part, I would like to talk about the mechanism of activation supporting T-cell tumor microenvironment. I think you have already known about this cancer immunity cycle, but the druggable point is this point. Of course, we had a lot of knowledge from the immune checkpoint molecule, but now currently we have only 2 available checkpoint inhibitors, such kind of anti-PD-1 or anti-PD-1 antibody mainly affect the effector phase of cancer immunity cycle, or anti-CTLA-4 antibody for affecting the priming phase. But now there are a lot of other drugs developed, such as TIGIT or TIM3 or the other LAG3 or such kind of other checkpoints. So we have to wait about the data maybe coming to next few years. And also, anti-VEGF antibody is so important for the immunotherapy of HCC. Of course, HCC are really VEGF-dependent tumor. That's why we focus on VEGF TKI for the developing last decade. But the VEGF had a lot of roles, not only the tumor growth, malignant tumor growth. VEGF improved the immunosuppressive tumor microenvironment. This is one of another role for the VEGF. That's why we should use about the anti-VEGF antibody combined with the immunotherapy. So I just summarize about this point: improving the immunoenvironment, increasing the effectiveness of immune checkpoint inhibitor for using about VEGF. So we inhibit Tregs or M2 macrophage or MDS cells by using about anti-VEGF antibody. That's why this kind of combination emphasize their effect compared with the PD-L1 monotherapy. So these kind of the mechanisms are already proved by the using about the tumor sample from the clinical trial. I would like to share about this information analyzed using a clinical specimen prior to the start of ICR treatment. This is the data from the phase 3 trial, combined phase 1B trial of the atezolizumab versus atezo This is called the GO30140 phase 1b study, and also some of the data from the InBrave 150 study. This data has already published in Nature Med in 2022, but I just summarized about the brief data. So if the positive of CD8, of course, the atezolizumab was so great data compared with the sorafenib. But if the CD8 are low, unfortunately, the Kaplan-Meier curve was so close in these two populations. And similar things are happening in the ratio of the effector T cell and T regs. If they are high, unfortunately, Kaplan-Meier curve is so close, but it's low. It means about ratio of Treg is not so high. This kind of we have a lot of beneficial for the atezolizumab. Glypican-3 low patient is a great beneficial for atezolizumab, and also AFP low patient has a great beneficial. So we have to know about not only the all patient had a beneficial for the immunotherapy. This is why we have to try to identify the real good biomarker for using about immunotherapy. This is another trial. And also this data compare with the atezolizumab versus atezo monotherapy. This kind of gene expression or higher population, it's mean about the really high the VEGF, gene expression of VEGF-A and VEGF-R2 receptor higher population. We do have a great beneficial of the atezolizumab compared with the atezo monotherapy. You can understand the mechanism, these kind of really understandable data. And also Treg is the cancer by the VEGF. That's why the Treg high population has a beneficial of atezolizumab compared with atezo monotherapy. Also, effector T cell high population and mirror high population has a great benefit from the combination of the anti-VEGF antibody combined with the PD-L1s. So these kind of data are really understandable when we think about the mechanism of the anti-VEGF antibody for the tumor microenvironment of the HCC. So, so understanding tumor microenvironment is so important. So when we analyze, this is the same data which I presented previously. Around 30% of patients are inflamed. It has a lot of cancer and T cells or the other immune cells are gathering to the tumor microenvironment. Unfortunately, in HCC, other 65 or 70 patients non-inflamed population. Of course, cancer-specific T cell must work for the ICI to have an anti-tumor effect. This is a really standard point. And also, ICI monotherapy is unlikely to achieve treatment effectiveness in advanced HCC. And the effect of the anti-VEGF antibody, anti-CTL antibody on tumor microenvironment enhance the efficacy of RCC. These kinds of points are really understandable, and we have to know before we start using about combination immunotherapy for HCC. So look at the next slide, look at the Kaplan-Meier curve of InBrave 150 and Himalaya patient. You can look at here, this Kaplan-Meier curve is so close compared with the sorafenib. This is the, unfortunately, those populations are non-variable population for using about ICC. That's why we needed to understand that there are certain patients who will not benefit from immunotherapy. So this is the other knowledge we have to know about immunotherapy. So this means about immunotherapy is not a, the magical agent for the HCC. So another point, why is the treatment of HCC so unique? And this is this single region that the liver is the one and only organ. So we always calculating about the liver function by RB score or the Child-Pugh score. But when we think about the liver function of the, a lot of mechanism of liver function, these two factors may not evaluate real liver function sometimes. So of course, we have high level of albumin patients, they are good liver function, it's really understandable, but some of the high level albumin patients had a high portal vein, high pressure of the portal vein, but those patients may have a not fully 100% of liver function. So sometimes we have to know their liver function, each patient by each patient. So that's why why we hepatologists treat over the HCC systemic therapy in current daily practice. So basic treatment concept of HCC, these 2 points. I think the other malignancy, it's really easy, just treat for the treatment against tumor. And also we are so happy for increasing about response rate or PFS, but HCC is different, but because we have to maintain liver function, this is another big role for the treatment strategy. So sometimes we use this kind of feature for the assessing liver function, but this is not the great 100% great assessment too. So sometimes we have to see other parameter for each patient, then understand about liver function and also maintain liver function in daily practice. So evaluation liver function is essential treatment selection for HCC. This is the important point. So let's look at BCLC algorithm. And today we have to focus on treatment stage D patient. And just I was focused on this point. Treatment stage D, any tumor burden with end-stage liver function, PS344, they recommend BSC. So look at this kind of patient. 60 is female, autoimmune patient, HBS antigen negative, HCV antibody negative, and child class C, ascites, splenomegaly, uncontrolled hepatitis, stenopathology, as early stage HCC patients who are not eligible for treatment. Of course, she is around 60. We have to consider about transplantation, but unfortunately, she did not have any donor, so we have to select the best supportive care for her. So that this kind of patient, we have to how to increase or recover liver function is so important. But sometimes we have only two for considering about the liver transplantation for those kind of population. Of course, HCC occurs in liver which has high potential carcinogenicity. This is another point we have to understand about treatment HCC. Of course, they have two metastatic two pattern of metastasis. First of all, the metastatic from primary liver tumor. This is really interesting. Same clone as a primary region occurs not only into hepatic but also the outside of liver. But sometimes we have to consider about multicentric occurrence of the HCC, different clone primary region. In clinical practice, many patients undergo a variety of repeated treatment. Each time they have a recurrence while maintaining liver function. This is an important point for understand the HCC's clinical history. Then also for last 30 minutes, I want to talk about immunotherapy. So since approval of the atezolizumab around 2020, in Chiba University, we treated nearly 200 patients, and then 80% of patients had a candidate of immunotherapy, and we can use atezolizumab or durable monotherapy. And 18% of patients, these patients had no indication of ICI treatment, and this is the reason of why we did not select ICI. Autoimmune disease, 9%, renal failure include renal failure patient or liver failure patient. We have, unfortunately, those kind of patients cannot select about ICI in daily practice, but 80% of patients can receive ICI in daily practice. Maybe these candidates are really similar from the other region. And then look at the clinical effectiveness of emerging issue of atezolizumab. In Japanese field practice, the age is a bit older compared with the BRAVE 150 patient, and also the rate of non-viral patient not so a big difference between the phase 3 trial and Japanese field practice patient. And those 50%, or most of those 50% had coexistence of the hypertension or the diabetes. That's why those had lifestyle disease. That's why they occurred HCC. So those lifestyle diseases is so important. We have to take about not only the tumor and not only the liver function, we have to take about this kind of lifestyle disease when we treat about atezolizumab. So This is advanced HCC patient seen in the past in the clinical practice in Japan, 70 years of male, and history of much local region, local aberration, and also the HCV without hypertension, diabetes. This is we had a past seen in the clinical practice. Early detection through surveillance and repeated recurrence and prognosis lesion to advanced HCC. This is one of the typical causes we had seen in the past in Japanese clinical practice. But nowadays, we always see these kind of patients, advanced HCC patients, recently seen in clinical practice. 80 is female, bit older than compared with the last decade, and both HbA and HCV are negative, and she had a hypertension, both hypertension, diabetes type 2A, and detected by some performed due to, mildly elevated AST and AAT noted by the primary care physician, and also not eligible for surveillance population. Unfortunately, she detected a huge nodule in here, giant tumor arising in non-cirrhotic liver. This is one of the typical case we have seen in daily practice recently. So this is the clinical effectiveness of imaging issue of this. You have to think about, of course, that the clinical effectiveness of current ICC treatment for HCC are not significant compared with other carcinomas. So you can see that if you compare the other malignancy, response rate is not so high, and PFS is not so long compared to other malignancies such as the non-small cell lung cancer and renal cell carcinoma and melanoma. And also, those malignancy had a great beneficial for ICC, but maybe if we compare with this kind of malignancy, maybe HCC a modest impact of ICI. So that's why we have to think about other things compared with other malignancy. And also, association of bevacizumab interruption baseline comorbidity is so important. If we use about anti-VEGF antibody for the patient who had either of the hypertension or diabetes, accumulated incident rate of the interrupted bevacizumab is so high compared with both without hypertension and diabetes. Also, cumulative incident rate of the interruption of bevacizumab treatment due to the anti-VEGF related adverse event with similar data come from this data. Because this really simple reason is we can explain the simple reason, because if the patient had hypertension and diabetes, those had a high risk for the proteinuria or the hypertension related to bevacizumab. That's why we have to interrupt or discontinue the bevacizumab. So unfortunately, some of the Japanese population had not so a great impact due to the bevacizumab interruption for their clinical course of using about immunotherapies. And also interruption of bevacizumab may reduce treatment effectiveness. This is from our data published in Cancer last year. This is 24 weeks landmark analysis. And then if we discontinue the bevacizumab within 24 weeks without prognosis, the PFS curve is really separately. And this is another data from the Dr. Hatanaka, and really similar data published in 2021 in Hepatitis Research. Bevacizumab interruption had reduced the treatment effectiveness of the atezolizumab for the advanced HCC. But of course, the other data came from the sub-analysis of IMBRAVE 150. Based on the clinical trial, the bevacizumab interaction had a less impact for both PFS and OS. So why these kind of things happen? Because the clinical studies population is really good population without other comorbidities. That's why the interruption has a small impact. But in daily practice, we have to treat about more advanced, more elderly patients with a lifestyle disease. So this is my personal opinion, but maybe this kind of difference of population may affect this kind of result. And also, in the clinical trial, bevacizumab can try again during their clinical course. That's why the patient can have the effectiveness with the bevacizumab interruption. Of course, during the treatment, we have to take care of the immune-related adverse event. Of course, these kind of things are not commonly happen when we use about anti-PD-L1 antibody plus monotherapy or anti-PD-L1 plus anti-VEGF therapy. But now we start using about anti-CTLA4 antibody treatment. These kind of rate are so increasing. So look at the data of the atezolizumab combination therapy. The treatment discontinuation rate is only 15.5%. Of course, half of patients had to interrupt either atezo or bev, but discontinuation rate of the atezolizumab is 15.5%. That's why this kind of combination therapy is so tolerable for using in clinical practice. And also the adverse event due to atezo combination therapy is we have to focus on the bevacizumab related AEs, such kind of hypertension, proteinuria, bleeding, and thrombosis. And also this is important data. Patients who discontinue treatment due to AEs have a low rate of transition to subsequent therapy. So now in Japanese Philippines, we can use about there are 8 regimens, so the sequential treatment is so important. So the management of the adverse event during the treatment is so important, and we have to moving on to other treatment after for the sequencing. That's why the don't discontinue due to AE is so important point. And also the AE leading to discontinuation are mostly IRAEs. So immune-related adverse event management we have to know about how to manage about IRAEs. And also, so next part, I would like to talk about focusing on intermediate stage HCC. This is the overall response rate of BCLC B patient, intermediate stage, from the data of the IMbrave 150. And the ORR rate is a bit higher than compared with the whole population. And look at this kind of data, depth of response is really good in both RECIST and MRECIST criteria. So maybe some population of intermediate stage are so candidate for the atezolizumab. And this is up to 7 criteria we sometimes using for assessing the, either we should use about TACE or the atezolizumab. This is one of the criteria, but these kind of criteria are so easy to understand and useful in the selection patient between about we should start from the atezolizumab or we should start from TACE. And I would like to show about some data from replacement trial. This is one of the Japanese trial, prospective study, multi-center, single-arm study, phase 2 study. Try to use the atezolizumab in the front line without TACE, without no TACE, and beyond up to 7 criteria. And 70% patients are included in this study, and the enrollment period so rapidly. And we compare this kind of population with the TACE group. This is exploratory analysis. We are gathering the TACE patient, historical data, January 2017 to December 2017. This is historical data, and we compare to do the propensity score analysis of this data. And this is baseline characteristics, a bit older patient included, and also the lot of patient had comorbidity like hypertension, diabetes. And you can see that this data and ORR is nearly 44.6%. So if we use about atezolizumab in BCLC B stage, maybe the expectation rate of ORR are a bit higher than compared with the advanced stage HCC. And also this is best change in the SLD from the baseline. You can see that it's great data come from this kind of data, and this is the spaghetti plot data. So this is PFS data and OS data, and the overall burden of PFS. This study made the assumption of statistical assumption. So this can present in ASCO 2023, And this is the important data. If we analysis in using about propensity score matching by using about taste group and atezolizumab group, and two methodology of propensity score matching, PMS and IPW, and both data had showed a great benefit of the progression-free survival of the atezolizumab and TACE. Atezolizumab had a great prolonged PFS longer than control arm of TACE. Of course, this study have a limitation because we have to compare the arterial therapies PFS and also systemic therapy PFS. This is one of the challenge for this study. That's why this study shows about this data for the exploratory analysis. But this is one of the message. Some of the population had a benefit from the systemic therapy in intermediate stage HCC. So this is A data. This is, you have to check about this data. So I would like to show another data from the another concept of the atezolizumab in daily practice. This so-called ABC conversion. This is advocate from the Professor Kudo. This is the editorial of the liver cancer in 2022. So when we use atezolizumab, of course, it had a great and overall response rate nearly 30%. But when we compare with this data from the other malignancy, I think the 30% is not enough for the moving on to patient cure. So, but in HCC, we have another tool, such kind of controlling liver nodule by other tools, such kind of resection or local ablation or TACE or the radiation therapy. These tools are so beneficial for the HCC treatment. So this is one of the concepts that, of course, nearly 30% of patients had the response by using about atezolizumab, but some of the patients moving on to progression during the after PR period. So this is really, concept is really simple. In case where the complete response is not achieved with RCI, adding curative or the local treatment may help achievement cancer-free. So this is a great concept for the unique concept for the HCC. So look at this case. He was the 73 years old male HCV positive patient with IVA and IVC invasion patient, we call previously. But after using about atezolizumab, the tumor necrosis happened like this, and the IVC shrinkage are decreasing. So we tried to moving on to the hepatic resection and achieve cancer-free and drug-free. This is a great goal for the patient. But so when we decide, this is one of the another clinical challenges. When we really decide about when moving on to the cancer-free or not. This is the data from our institution, and you can see this kind of spider plot. This is the line of 6 months. There are only a few cases market tumor shrinkage after 6 months. This is really important data. So this period, 3 months to 6 months, if we can try to moving on to the curative approach, we have to do that. This is one of the messages from this data. The median time to response was 3.2 months. Maybe within 3 months, it's a bit early because some of the patients decrease after 3 months, but after 6 months, no patient, only few patients market with tumor shrinkage after 6 months. So this line is very important for the general practice. If we have a chance, we have to moving on to cancer-free around 6 months. So this is one of the markers. The 70s male patient, both HCV and HCV negative type A5 patient, multi-nodules, not only the right lobe but also left lobe. You can see these nodules. After use of atezolizumab, tumor shrinkage is happening, necrosis lesion, but they have enhanced area around here, only this part. 6 months later, I talk with the patient. You have to moving on to other approach, but this period, we have no data about this kind of timing. So I just tried more 6 months, but nothing happened, changing. They are remaining tumor. Then I discussed with the patient, and also the patient tried to receive TACE after starting 16 months from atezolizumab. And look at this, in achieving cancer-free. But when we review this data, this patient's data again, we have to decide cancer-free around 6 months. So that's why I told about the timing is so important. So maybe if we try to taste in this timing, he don't need to receive atezolizumab more than 10 months. So maybe economically, it's he don't need to come to hospital. So I think now we decided to moving on to cancer-free around 6 months. So we had another approach for the achieving cancer-free, the particle beam therapy, like a proton therapy or heavy ion radiotherapy. This is one of the unique radiation therapy which we can use in a limited institution in Japan. Now we can cover by the Japanese healthcare system. If patient had a 4 centimeter larger nodule and who can achieve the curativity, patient can receive with the Japanese healthcare system. Even large liver cancer can be treated with a minimum impact on liver function. This is important for maintaining liver function by using large nodule in liver with a cirrhosis. So maybe this kind of approach had other beneficial for achieving cancer-free in general practice. So after considering the therapeutic effect of combination therapy, this is one of the summarized. If aiming for the cancer-free, drug-free transition curative therapy is so important, we have a lot of tools, so we have to select each of them in the general practice. And also sequencing systemic therapy, so prolonging and their survival. So the patient unfortunately cannot achieve cancer-free. We try to sequencing the H regimen, not all, but some of the regimen, then prolonging survival. This is one of the 2 different strategies for using about atezolizumab. So I would like to show about the data of the cancer-free in Japanese and 732 patients in our institution. We're gathering about the patient who received systemic therapy in first time. Then, if the patient achieve cancer-free, overall survival is so excellent. But achieve cancer-free rate of the is only 33.3% by gathering the data of the VEGF TKI and also the atezolizumab. So let's analyze about separately. Sorafenib group only 2.1%. So this is a really rare population who achieve cancer-free. Then Batinib 3.6%, bit higher, but no big difference between sorafenib and lenvatinib. Now atezolizumab 7.7%. This is slightly increasing now. And also let's look at the characteristics of the who can achieve cancer-free rate. This morning we have several papers who discuss about the cancer-free rate. But look at here, maximum tumor size. Some of the atezolizumab patients have more than, maximum tumor size of intrahepatic region are more than 142 patients. But this kind of population had a potential for shrinkage and moving on to cancer-free. This is tremendous things which we face on in daily practice. Also, you can see here some of the VP4 patients achieve, one patient, VP4 patient achieve cancer-free, and also as well as a VP3 patient. So I think the immunotherapies had a different mechanism compared with the VEGF TKI. That's why we face on the dramatically response patient daily practice. But mostly, most of the big tumor patient who had a big tumor patient cannot disappear their tumor. So that's why we have to combine with the other 2 in daily practice. So this is data from the Professor Kudos, and the patient with a curative conversion had a good PFS. OS really, this is kind of really understandable data. And also similarly, patient with a CR and who drug-free had a good PFS. So of course now we had less than 10%, but the goal is cancer-free and drug-free. So this is the aim for starting about systemic therapy in daily practice. So this is one of the final slide of my talk. So nowadays we had tremendous agent. Of course, we have to develop another agent, like the two combination immunotherapy with other agents, such kind of PD-L1 plus TIGIT plus anti-VEGF, or the other kind of mechanism, or the other mode of action drug. We cannot talk about this kind of sponsor session, but ICI treatment may be prolong patient survival more and more. However, that when we compare with the other malignancy, as I presented previously, the response rate of the immunotherapy is not so higher compared with other malignancies. So we have to combine with this kind of traditional tools, such kind of surgical resection, local ablation, or TACE, or the particle ion radiation therapy with ICI treatment. This kind of treatment strategy may prolong patient survival, once it is patient survival more and more in near future. So we had and collaborate each other with the surgical department or the radiational department, and also we should discuss about patient by patient and gathering data, and also we have to publish about those data in this kind of congress. So takeaways, this is the final talk, my final slide of my talk. The HCC disease landscape is rapidly evolving due to two factors. As I presented, the first part is eradicate and control hepatitis virus, and notably increase in lifestyle disease. This change initially began in Japan, but will spread in both Eastern and Western countries in near future. This is my personal opinion, but HCC may be one of the final hallmark of lifestyle disease. So we have to not only take about the tumor, not only take about the liver disease, but also for the management of the lifestyle disease is so important. And also immunotherapy for HCC is still in its early stage compared with other malignancy. And there are a lot of great data coming to the from the other malignancy, such as ESMO Congress heading on the last weekend also. But and also the research is in this field is currently lagging behind other carcinoma. So we have to learn about a lot from the other malignancy, like this morning Professor Omata talked at this point. So in HCC, it is essential not only to treat for the tumor, but also comprehend the liver and also lifestyle disease and organ from which cancer originate, and presenting its function in order to prolong survival. This is one of my conclusion, and I always working about a lot of collaborating with daily practice, and these data come from these collaborators. And thank you again for joining this sponsor session. Thank you very much.
Thank you, Professor Ogasawara. It's very comprehensive lecture of HCC treatment from etiology and history of HCC treatment, and mechanism of immunotherapy, and characteristics of HCC treatment, not only tumor, but also liver function, and also cancer-free. Okay, there is more than 5 minutes. Is there a question from the floor? Okay, I want to ask a couple of questions. One is first part you lectured about etiology changing from non-viral to non-viral, and also size of liver cancer is large, and but no cirrhosis.
Mm.
Japan's success to surveillance in the era of viral HCC, but how next stage for the non-viral HCC? What kind of surveillance is good in your opinion?
That's a good point. So of course, previously, viral hepatitis patient, we had a lot of viral hepatitis patients, so we can easily to gathering those patients for the high volume center. That's why a lot of elderly and physician done in the last 30 years. But we had a tremendous number of the lifestyle disease patients. So it's sometimes really difficult because it's easy to identify the cirrhotic patient by using a FIB4 index or something. Of course, that's collaborating with the diabetes patient, physicians, doctors. It's really important. But non-cirrhotic patient, it's really difficult.
Yeah.
So sharing the information with those kind of patient and go to some of the personal examination by their monies or something is the other strategy, I think.
Thank you. It's very difficult, and we have to challenge.
Challenge, yeah.
Yes. And another question is, you show your data, intermediate stage is a very good response, about more than 40% response, and also INBRAVE 150 also more than 40%. What difference between BCLC-B and C? Because maybe those intensities are almost same, but the response is quite different, and maybe both hepatocellular carcinoma, moderate, or its content is almost same. But what makes the difference between the efficacy of intermediate stage and advanced stage? What is your opinion?
That's a good question, because when we check about just response rate, BCLC-B patient higher than BCLC-C patient is good, and it's and we always seen that kind of data. So when we see the patient daily practice, this is my personal opinion, but the huge nodule, sometimes difficult shrinkage, like a PR. This is the limitation of the immunotherapy. And this is not only happen in HCC, but also happen in other malignancy. But maybe the size is sometimes important for achieving the partial response. So that's why the rate of the intermediate stage is a bit higher compared with the advanced stage HCC. This is one reason. The other reason, maybe combination immunotherapy just broke only anti-VEGF and anti-PD-L1. So they only broke two mode of action. So, but advanced stage HCC, such kind of the patient who had a potential for the metastasis other region of the invasion to the hepatic vein or the portal vein, maybe those patients have more malignancy potentials. So I think these kind of difference maybe this is that's personal opinion, but maybe related to the response rate compared with the intermediate stage and advanced stage. But we should try to research this point.
Yes, thank you. And last question is, just recently, result of INBRAVE 050 is published in the Lancet. Do you think that kind of adjuvant therapy makes impact in HCC treatment in future?
That's a good question, and also, of course, this is sponsored seminar, so I cannot prepare that kind of slide this session. But let's think about that other malignancies, such kind of lung cancer, or the gastric cancer, or colorectal cancer, or the pancreatic cancer. They all have established adjuvant therapy, but there are no systemic therapy in HCC. So not the whole population, but some population had a huge benefit for the adjuvant HCC. Of course, if we have the adjuvant treatment, maybe the surgeon try to remove the HCC more aggressively. Maybe those kind of the challenge may prolong not direct after the acceptance for the using about atezolizumab, but maybe if they use a few years, maybe we can find about beneficial population of adjuvant treatment in HCC. Then those kind of data may tend to prolong patient survival.
Thank you. Is there any question from the floor? No? Okay, I will close this luncheon seminar. Thank you for very nice presentation and
Thank you very
lecture.
much.
Thank you.
Thank you very much to Dr. Yamashita and Dr. Ogasawa. Luncheon Seminar 2 is now closed.